Hello and welcome to another Dr. Barbara Miller NCLEX review session. Today we're going to be talking about the neurological system. Okay, so let's do a little bit of a refresher. The anatomy or the brain anatomy. Let's start with the cerebrum, which consists in the right and left hemisphere. Each one receives sensory information from the opposite side of the body. You have the cerebral cortex, the outer gray matter. Frontal lobe of the brain contains the motor cortex and the Broca area, which is the speech function. You have the parietal lobe, contains the sensory cortex. The occipital lobe contains the visual cortex. The temporal lobe contains the auditory cortex, and the Wernicke's area for comprehension of verbal and written language. Then you have your thalamus, relays sensory impulse that helps the cerebral cortex produce voluntary movements. Then you have the hypothalamus. The hypothalamus regulates responses to the sympathetic and parasympathetic nervous system, regulates the stress response, sleep, appetite, body temperature, fluid balance, and emotions. Also responsible for the production of hormones secreted by the pituitary gland and the hypothalamus. That's the brain stem. You have your midbrain, the motor coordination for visual reflex and auditory relay centers. You have the pons, that's the respiratory center, and regulates our breathing. And you have the medulla oblongata, contains afferent and efferent tracts, and cardiac, respiratory, vomiting, and vasal center. It controls the heart rate or respiration, blood vessels diameter, sneezing and swallowing, vomiting and coughing. And you have your cerebellum, coordinates our muscle movements and equilibrium and muscle tone. The neuro has autonomic nervous system. You have your sympathetic nervous system, which is the adrenergic. That's the fight or flight response, originates at the T1, okay, the thoracic one, and lumbar 2 in the spinal cord. The effects increase cardiac output, vasoconstrictions, increase our blood pressures, bronchodilations, pupil dilation. It decreases secretions and peristalsis. It increases our perspiration. Parasympathetic, also known as cholinergic, the rest and digest. That's originate in S2 and S4 in the spinal cord. The effects of parasympathetic decrease our cardiac output, vasodilation, which decreases our blood pressures, bronchial constrictions, pupil constrictions, increased secretions, and peristalsis, which also increase our salivation, okay, bladder contractions. Some diagnostic tests that you should get familiar with when you're dealing with the neurovascular and throughout your nursing, like what is a computer tomography, a CAT scan, and it's a brain scan that may or may not require injection of dye. However, in the event that they're going to be using contrast, you want to ask your patient if they're allergic to any dye, iodine, or shellfish, okay, because that could impact negatively if they do have an allergy for those things. The pre-procedure, as said before, assess for allergies to iodine, contrast dye, shellfish if using dye. You want to withhold, say the patient is on medication, say a metformin, if the iodination contrast dye used, the risk of metformin-induced lactic acidosis. Okay? Post-procedure fluid replacement is paramount. Monitor, you want to monitor for allergies to dye. You want to assess injection site for bleeding. Another diagnostic test that you should get familiar with is the magnetic resonance imaging, also known as MRIs. It's non-invasive procedure that identifies tissue, tumors, vascular abnormalities. It also provides more detailed picture than that of a CAT scan. However, you do have patients who are claustrophobic, so you want to ask if they are claustrophobic for an MRI diagnostic procedure. Pre-procedure, you want to remove all metal objects from the client or your patient. You want to make sure patient doesn't have metal implants, pacemakers, implanted defibrillator, hip prosthesis, vascular clip. It's also contraindicated in pregnant women. It increases temperature of the amniotic fluid. You want to assess for claustrophobia. Post-procedure, patient resume normal activities. Another diagnostic test is the cerebral angiography, injection of contrast, usually through the femoral artery into the carotid artery to visualize cerebral arteries and assess for lesions. Pre-procedure, you want to again assess for any allergies to iodine, shellfish. You want to assess for the renal function. You want to withhold anticoagulation meds, okay, such as Plavix, aspirin, okay. Patient should be NPO for 4 to 6 hours before the procedure. You want to assess and mark the distal pulse to easily recheck them post-operatively or post-procedure. For post-procedure, you want to monitor for swelling of the neck and difficulty swallowing. Bed rest for 12 hours. You want to check insertion site for bleeding. You want to keep the extremities straight and check for blood flow distal to the puncture site. Uh, the pulses and capillary refill, you want to check all that. You want to check the site for color, and you want to increase fluid intake. Another diagnostic test that you should get familiar with is electroencephalography, EEG. This is used to identify seizure disorders and other conditions. Electrodes placed on the scalp to record electrical activity in the brain. Pre-procedure, wash the patient's hair. You want to withhold coffee, tea, caffeine beverages, antidepressants, tranquilizers, and seizure medications at least 24 to 48 hours before the test. No NPO needed for this. The patient can have breakfast. During the procedure, hyperventilation or strobe lights may be used to increase seizure activity. Post-procedure, wash patient's hair, safely precaution for a patient who was sedated. A diagnostic test continue like a lumbar puncture. Okay, lumbar puncture is sample, they're looking for a sample of cerebral spinal fluid obtained from the insertion of a spinal needle at lumbar 3 and lumbar 4 site. It is used to diagnose meningitis, subarachnoid hemorrhage, or some other neurological disorder. It is contraindicated in patients who has increased intracranial pressure. Please remember that. Pre-procedure, have the patient empty the bladder, position patient on the side in a fetal position, lateral recumbent position, or stretched over the table while sitting so the back is arched. Post-procedure of a lumbar puncture, you want to lay flat, have the patient lay flat for several hours, increase fluids, monitor for cerebral spinal fluid leak, which can cause headaches. Like an epidural blood patch may be necessary. And remember, a positive glucose test can determine whether the patient is leaking cerebrospinal fluid. You need to know what to assess when you're dealing with patient has neurological disorders, like the respiration. Know that a Cheney stroke rhythm with periods of apnea, where the patient stops breathing for a couple of seconds, can indicate metabolic dysfunction or dysfunction in the cerebral hemisphere or basal ganglia. Then you have your neurogenic hyperventilation, regular, rapid, and deep sustained respiration. This indicates a dysfunction in the low, mid-brain, and middle pons. Apneic is irregular with passes of the end of inspiration and expiration. Indicates a dysfunction in the middle of the caudal pond. Ataxia, totally irregular, that indicate a dysfunction in the medulla. and cluster to breathe with irregular space pauses dysfunction of the medulla and pons. Go back and check your med-surg book, and you'll see pictures of decerebrate and decorticate posturing. So what is decerebrate? Is an extensor or brain lesion, and in contrast, a decorticate posture is flexor cortex problem, cerebral dysfunction. Flaccid, when the patient looks flaccid, no motor response in any extremities. So please go back and look at pictures of decorticate and decerebrate posturing. Also, I would like for you to take a look at Kernig's and Brzezinski sign. Those are indicative of meningitis. So meningeal irritation, irritability, nuchal rigidity, severe headaches, tachycardia, nausea, and vomiting, photophobia, nystagmus, abnormal pupil reaction, and eye movement. So the Kernig signs, this is when the patient lost the ability of a supine patient to straighten the legs completely when it's fully flexed, and the knee and hip. So Kernig sign is the loss of the ability of a supine patient, not a spine, a supine patient to straighten the leg completely when it is fully flexed at the knee and hip. And in contrast, the Brzezinski sign, involuntary flexion of the hip and knee when the neck is flexed. Motor response, hemiparesis, hemiplegia, and decreased muscle tone. Memory changes. Patient will have short attention span. Personality and behavior changes. Look at the reflexes. Deep tendon reflexes, biceps, triceps, brachial and quadriceps. Superficial reflex, you have your plantar, your abdominal, and you have your Babinski. Remember, the Babinski reflex should not be present after 1 year. That may be indicative of a tumor, a brain tumor. Go over your reflexes, reflex activity. Absence to no response is a 0 reflex. Weaker than normal equals a 1+ reflex. And the reflex that is 2+, that is normal. Stronger, more brisk, you would consider that as a 3+, and hyperactive is a 4+. So go over and know your reflexes. You may have questions on your NCLEX pertaining to reflexes. Remember, the normal is a 2+. Also, you want to ascertain the patient's level of consciousness. You could also use the Glasgow Coma Scale, which has 3 phases. The eye is spontaneous, you would give a 4. The eye open to voice, you will give a 3. The eye is open to pain or no eye contact at all, none, you'd give a 1. Verbal, is that patient verbal? Oriented, you'd give a 5. Is that patient confused? You're going to give a 4. Is that patient uses inappropriate words? You'll give a 3. Is that patient make incomprehensible sounds? You give a 2. If that patient is not making any type of sounds, you're going to give a 1. And the motor part of the Glasgow, is that patient able to obey command? You're going to give a 6. Localized or pain, you're going to give a 5. Withdrawals, 4. Flexion, 3. Extension, 2. Or none, a 1. Remember, a Glasgow coma scale, that is 3. The patient is in a deep coma. So it goes from 3 to 15. A patient is in a deep coma if the Glasgow scale is at 3. The patient is in a comatose situation when the Glasgow coma scale is less than 8. And the normal Glasgow coma scale is 15. So it ranges from 3 to 15. Also, you need to know about the increased intracranial pressure. Know that the normal ICP is between 10 and 15 millimeters of mercury. When it's elevated, it's going to be greater than 20 milliliters of mercury. Know about what is a Cushing triad. A triad where the blood pressure is going to go up, the systolic part of the blood pressure is going to be elevated, the pulse is going to lower, and also the respiration will be lower. What medication can you give for a patient with increased intracranial pressure? You want to give osmetrol or mannitol. Medication, osmotic diuretics, mannitol or osmetrol, and steroids, dexamethasone. You want to avoid opiates and sedatives unless ventilated. Will restrict the neurological assessment. You want to give acetaminophen, Tylenol for fever. Barbiturate places the patient into a therapeutic coma with ventilator and cardiac monitoring. Go over the different types of headaches, like a migraine headache. Remember, with a migraine headache, it's a neurovascular disorder causing unilateral, on one side, throbbing headache that persists for 4 to 72 hours. Okay? Poorly understood, the prevalent, possibly caused by activation of the central nervous system and the cerebral arterial vasodilation. What are the risk factors? Women is more at risk for migraine or family history. It's in our DNA. You got to know the triggers. What are some triggers of migraine? Headaches, bright, flashy lights, stress, anxiety, menstrual cycle, sleep deprivation, foods with monosodium glutamate, MSG, tyramine, and nitrites, like aged cheese, bacon, salami, those type of cured meat could trigger a migraine headache. How do you treat it? Non-steroidal anti-inflammatory drugs for mild migraine, antiemetics, caffeine such as sumatriptan or ergotamine for severe migraine, sumatriptan or ergotamine for severe migraine, prophylactic medication for antihypertensive medication and anticonvulsant. The nurse must promote a dark, quiet environment. And in contrast, a cluster headache. What is a cluster headache? What is a cluster headache? Severe sudden headache, pain that lasts for 30 minutes to 2 hours. It happens daily at the same time for months. What are some clinical manifestations? Severe unilateral non-throbbing headache around the orbital region, facial sweating, nasal congestion, droopy eyelid, excess tearing, agitation, and pacing. How do you treat cluster headache? Oxygen therapy, somatriptan, ergotamine, verapamil, and corticosteroids. You have types of head injury. You have open and closed injuries. Open the scalp like a laceration, fracture in the skull, interruption of the dura mater. Closed, concussion, contusion, and fractures. The skull fracture. What are the causes of a skull fracture? Could be a motor vehicle accident, a fall, a firearm related injury, an assault, spot related injury, recreational accident. Any of those factors could cause a skull fracture. Death can occur at 3 points in the time after injury. Immediately after, within 2 hours after, or 3 weeks after. Scalp laceration, highly vascular, high risk of blood loss. What are some types of fracture? Simple, comminuted, or depressed skull fractures. So what is simple? It's a break in the continuity of the bone. Comminuted is a splintered or multiple fracture, or depressed fracture occurs when the bones of the skull are forcibly displayed downwards. You have your basal skull fracture. Is a fracture of the base of the skull. It allows cerebrospinal fluid to leak from the nose and the ears. And to confirm that, you want to use the glucose stick, and if that is positive, it could confirm that the patient is leaking cerebrospinal fluid and may require further care. Signs of basilar skull: the raccoon eyes, periorbital edema and ecchymosis, or the battle signs, auricular ecchymosis noted on the mastoid bone. Testing for cerebrospinal fluid is the dextrostick or test tape strip. They also will have the halo signs. Halo signs allow drainage to leak onto a white gauze pad. Within a few minutes, blood should gather in the center and the cerebrospinal fluid will create a yellow ring around the blood. Remember, spinal cord injury, partial or complete disruption of nerves and neurons resulting in paralysis, sensory loss, altered activity, and autonomic nervous system dysfunction. What manifestation by levels of injury? Cervical, partial, or complete. Respiratory dysfunction. Patient may be on the ventilator with a C4, increased loss of system function. Partial or complete paralysis of all four extremities, loss of bladder and bowel control, alteration in sexual dysfunction. Thoracic injury, partial or complete paraplegia, where the patient will have loss of bladder and bowel control, alteration in sexual function, partial or complete paralysis of the lower extremities, and major control of body trunk. Potential complication of autonomic dysreflexia, injury above the thoracic 6. Respiratory complication or complications, lumbar, partial or complete paralysis, lower extremities, loss of bladder and bowel control, alteration in sexual dysfunction. Go over what is a paraplegia, injury below thoracic 1. Patient will have paralysis or paresis, weakness of the lower extremities. Quadriplegia, injury in the cervical region, paralysis or paresis of all four extremities. And hypertonia, injury to the upper motor neurons above the lumbar 1 and lumbar 2. Spastic muscle tone, spastic neurological bladder. And hypotonia, injury to the lower motor neurons below lumbar 1 and lumbar 2. Patient will have flaccid muscle tone, flaccid neurogenic bladder. So what are some interventions? You want to stabilize the spine, maintain patient airway, which is paramount, monitor vital signs, prevent pressure injuries. You want to monitor for spinal shock, loss of sensation, flaccid paralysis, and reflexes below the level of injury. You want to monitor for neurogenic shock, where the patient will have decrease in blood pressures, heart rate, and cardiac output. You want to monitor for autonomic dysreflexia, which is a life-threatening situation. Okay, severe hypertension triggered by noxious stimuli below the cord damage, which caused by impaction, bladder distension, and pressure points or ulcers and pain. Autonomic dysreflexia is severe hypertension. Remember that. With bradycardia, patient will have headaches, flushing, goose bumps, or piloerection, sweating, nasal congestion. You want to put that patient in a high Fowler's position to help decrease blood pressure, loosen the constricted clothing if the patient has. You want to determine what's the causative stimuli. You want to teach patient about bowel and bladder management. You want to administer medications as ordered. Therapeutic measurement. Immobilization, spinal board, hollow traction, Gardner-Wells traction, or the Crutchfield tongues, or cervical collar. Go over what is a hollow traction and move the patient as a unit. Do not apply pressure to the rods. Make sure the wrench or the wrench screwdriver are attached to the vest to release patient from the device in the event of an emergency. Skeletal traction. You want to go back over your traction. Skeletal traction is used to realign or reduce injury when skin traction is not possible. The rope pulls and weights are used. Tractions need to be maintained at all times. Weights must hang freely, and the knots in the rope are tied securely. Let's talk a bit about seizures. You will encounter questions on seizures. Generalized seizure, let's start with the tonic-clonic, also known as the grand mal seizure. Tonic-clonic seizure may begin with an aura. The patient may smell something or something happening where the patient knows that they're going to be having seizure shortly. So the tonic phase involves stiffening or rigidity of the muscles of the arms and legs, and usually lasts 10 to 20 seconds, followed by loss of consciousness. And the clonic phase consists of jerking of the extremities and hyperventilation, and usually lasts about 30 seconds. Full recovery from seizure may take several hours. Absent seizures, also known as the petit mal seizure, that's a brief seizure, lasts for seconds, and the individual may or may not lose consciousness. No loss of or change in muscle tone. Seizure may occur several times during a day. The victim appears to be daydreaming. This type of seizure is more in children. Remember, absent seizure more prevalent in children, also known as the petit mal. Myoclonic seizure present as a brief, generalized jerking or stiffening of the extremities. The victim may fall from the seizure. Atonic or actinic drop attack. An atonic seizure is a sudden momentary loss of muscle tone, the patient may fall. Then you have partial seizure. Partial seizure, known as simple seizure, usually without alteration of consciousness. Simple partial seizure, sensory symptoms, and complex partial, usually with impairment of consciousness. Remember, there are phases of seizures. You have your prodromal, your oral, your ictal. What is the prodromal? Symptom preceding seizure, nervousness, lightheadedness. The oral, sensory, warning, or ictal, the actual seizure. And post-ictal, altered state of consciousness can last from 5 to 30 minutes after a seizure. Remember, the nurse should stay with the patient. You want to position the patient in a sidelining position if it's possible. Don't put anything in the patient's mouth. Don't restrain. You want to remove any harmful things from, where the patient is seizing. Know your different medications that they use for seizure, such as your dilantin, your phenytoin. The boards may ask you, patient is on dilantin, you want to ensure proper mouth care, okay? Because phenytoin or dilantin causes hypertrophy of the gum or malodor of the mouth. Carbamazepine, valproic acid, phenobarbital, levetiracetam, and topiramate, for lack of better pronunciation. So all those are medication that utilizes for seizure. Know what is status epilepticus? It is a life-threatening situation where there is a prolonged seizure greater than 5 minutes, or falls to regain consciousness is in between seizure. What are the risk factors? Central nervous system infection, head trauma, drug withdrawal, or toxicity. How do you treat it? Lorazepam. Lorazepam is the medication of choice to treat patient who is going through status epilepticus. Diazepam also, and phosphatone. Phenytoin IV slowly, you want to give that 50 milligrams per minute. Don't mix with glucose. Administer in normal saline, 0.9 isotonic fluid. You want to monitor for bradycardia and heart block. The last of the neuro, we're going to talk about stroke, or TIA, trans ischemic attack. Sudden temporary episode is a neurological dysfunction lasting usually an hour, secondary to decreased blood flow to the brain. So TIA is like a warning sign. What's the risk factor? Advanced age, male, it has genetic components, high blood pressures, high lipidemia, okay, diabetes mellitus, smoking, atrial fibrillation. What are the clinical manifestations of a transischemic attack? Sudden change in visual function, sudden loss of sensory or motor function. How do they diagnose that? The carotid ultrasound, or CAT scan, or MRI, or arteriography, or the 12 lead EKG. How do they treat stroke? Angioplasty, carotid endarterectomy, removal of a plaque, or they're going to give antiplatelets, okay, anticoagulants. The nurse must instruct patient to use the DASH, D-A-S-H diet, high fruits and vegetables, moderate and low fat, dairy products, low animal protein, and want to maintain body weight with regular exercise, and smoking cessation is paramount. One more, let's talk about multiple sclerosis. You may encounter questions on multiple sclerosis, which is a progressive autoimmune disorder, causes destruction of the myelin sheath, of the nerve fibers and neurons in the brain and spinal cord. It characterized by periods of relapsing and remitting. And women is at a high risk factor between 20 and 40 years. What are some signs and symptoms of MS? Vision problem, diplopia, nystagmus, muscle spasticity, and weakness, balance and problem, bladder bowel dysfunction, cognitive changes, fatigue, emotional changes, and pain. Where are the labs? MRI. They also will do the lumbar puncture and increase protein in the cerebrospinal fluid. Treatment are immunosuppressant, anti-inflammatories, and muscle relaxant. And nurse should instruct patient to avoid triggers. Temperature extremes, stress, and fatigue. Next one is myasthenia gravis. It's also an autoimmune disorder that causes severe muscle weaknesses, characterized by a period of exacerbation and remission. What are the signs and symptoms? Muscle weakness, drooping, okay? They diagnose this with atropion or tensilon test, okay? So you want to go back and look at that. How do they treat myasthenia gravis? With anticholinesterase, like pyridostigmine, antidote, atropine, immunosuppressant, prednisone, immunoglobulins, procedure for plasmapheresis, and thymectomy. Nurse should maintain a patent airway with patient who is in myasthenia crisis. Tape eyes shut and to prevent corneal dryness. Another one is the Guillain-Barré syndrome. It's another acute autoimmune attack affecting the peripheral nervous system that causes a sudden onset of weakness and paralysis. Okay? Patient will have respiratory and GI or viral infection could be the cause. What are the signs and symptoms? Symmetrical weakness, hyperflexia, paresthesia, and pain. Treatment, immunoglobulin, plasmapheresis, may need mechanical ventilation. You want to maintain a patent airway. Last but not least, Parkinson's. You are to go over your Parkinson's That's another progressive disease causing muscle rigidity, akinesia, and involuntary tremors caused by loss of pigmented cells and substantia nigra and depletion of the dopamine. What are some signs and symptoms? Muscle rigidity, tremors, slow shuffling gait, mask-like expression. How do they diagnose that? By looking at the symptoms to rule out neurological disease. Treatment: levodopa and carbidopa, bentropine or dopamine agonist. Monitor swallowing and food intake to avoid aspiration. And thank you so much. We'll be doing part B of the neurovascular system. Please like, share, subscribe, and leave your comment for improvement. Thank you once again to listening to this video. Hope it can be benefit and increase your knowledge in neuro. Thank you.